Early clinical exposure is a recent addition. It has been added in recent years in the first prof syllabus by the National Medical Commission. So it's not as if there are lots of reference points for it. What do you mean by clinical exposure? There are 19 subjects in medicine, and all of them have clinical application to it. So anything can be asked from any subject. Well, let's first go through some of the aspects related to these types of questions, and then we will actually discuss the questions. First thing, why are they different? Because look, normally you are used to just by heart a material from the book and then recall it in the exam, right, as such, right, as it is, and then you feel happy, you feel satisfied that you've written everything, you get marks. Clinical cases are going to be different every time. Anyways, in every exam there is a surprise element, and clinical case might be one of them that you will not have read that clinical case per se previously. That means you will have to have some kind of an analytical mind while approaching these questions in the actual exam. So you already have the knowledge, just need to put it, integrate it, analyze the question, and then write the answer. How to approach these questions? Always find the keywords or phrases, key phrases in the question. Look, the question will be a case given to you, and then there will be 3 or 4 questions asked on that case. Now there will be key phrases in that case itself. For example, a female came with weight gain and intolerance to cold, and then other information is given. Now you know this is the key phrase, it's about the hypothyroidism, and then you will be asked to write physiology part. Okay, nobody is going to ask you the diagnostic tests or treatment management part, etc. For most part you will have to write the physiology. So look for the key phrases. You know, for example, in the questions that are asked on the clinical case, there may be a mention of, let's say, describe the afferent and efferent connections of this part of the brain. Now you start thinking in which part you have read afferent and efferent connections. Do you know, can you recall? It's in the cerebellum that you read afferent and efferent connections extensively in physiology, I am saying. So immediately it should strike to you that this is cerebellum, and then you will have to write the physiology mostly for most part of the question. All right, so locate where you have actually read this phrase, and then write physiology, not medicine or pharmacology or pathology. All right, so with this in mind, let's see some of the catchphrases, and then we will actually see the cases in the end. Okay, CVS, there will be phrases like pacemaker was implanted, or there was a conduction block, irregular heartbeat. Now these things means it's about the conducting system of the heart, special junctional tissues, and they will ask you what are the parts of this particular system, etc., etc. Very often the question itself gives you the hint. I mean, in CVS, once you have located that the case is related to the CVS, and then they ask you what are the parts of this system, it's a catchphrase. This is parts of the conducting system. Okay, heart sounds, murmurs, stenosis, regurgitation. This is generally required in the cardiac cycle. So the question definitely is on the cardiac cycle, and then you will be asked to write the cardiac cycle. Tachycardia, end diastolic volume, breathlessness, edema on the dependent parts. All this will be about the heart failure, and where actually the question is on the cardiac output. So they will be asked, they will be asking about the cardiac output, stroke volume, preload, afterload, etc. These will be the questions. Because in the heart failure, you know, stroke volume decreases, cardiac output decreases. So that's a key phrase. Then blood pressure will be mentioned, high blood pressure, and left ventricular hypertrophy, which occurs because of the high blood pressure, hypertension. So it's a question on blood pressure. Look, it is so simple that they will just say in those questions, describe the short-term and long-term mechanisms of this particular thing. So you know, where have you read in CVS short-term and long-term? Blood pressure regulation. Look for such phrases. Low blood pressure, thready pulse, cold and clammy skin, and sweating. This is definitely a typical case of circulatory shock. They will say accident victim, and the victim is bleeding, and then is brought with these manifestations. See, in the question, there will be describe the stages of this particular condition. Now you know that where have you read stages in the CVS of what? It's about the shock, the compensated stage, progressive stage, irreversible stage. So you will get clues, ample clues in the question itself, which question is being, what is being asked, and you can write accordingly. Okay, CNS, there will be intention tremor, waddling gait, hypotonia, pendular knee jerk. These are the signs of cerebellar disease. So they are asking cerebellum. Again, afferent and efferent connections of this part. You know, you have read this in physiology in the context of cerebellum. Okay, pill rolling tremor, mask-like face, lead pipe rigidity. These are the symptoms of Parkinsonism, and therefore the question is on the basal ganglia. In the GIT, there may be pain in abdomen, which is relieved by food, or vomiting, hurry, worry, curry. All these phrases means it's a peptic ulcer and you are being asked gastric juice. Most commonly in the GIT, they will ask gastric juice and pancreatic juice. So for the pancreatitis and pancreatic juice, there will be phrases like steatorrhea, increased fat excretion in the stools, malabsorption of the nutrients, because pancreas secretes all the digestive enzymes. In pancreatitis, there will be deficiency of those enzymes, and therefore those nutrients will not be absorbed and fat will be lost in the stools. So you can easily guess and then write accordingly. Endocrines will be the easiest if the case is on endocrines, or if the question is on endocrines, like they will say prognathism was seen in the patient. So it's a growth hormone, weight gain and cold intolerance, hypothyroidism, buffalo hump, Cushing syndrome. Endocrines will be the easiest part. So this was these are some of the phrases, key phrases which I could think of. Now we will go to the real questions which have been asked previously. Before we start with this, again, many students are thinking that there will be notes or video on the clinical cases. You will go through them and one of them will be asked in the exam and you will answer. You will have to give up this tendency once and for all. There will be new things in the exam, particularly in the clinical cases. So you will not have read that before the exam. You will have to apply your mind then and there. Go with this tendency, then your anxiety and stress will be less. Okay, let's see the cases now. Okay, I'm trying to just make it more visible. If it is not, I'm reading it out. A 35-year-old person present in the OPD with severe blood loss due to road traffic accident. So apparently it might appear to you as a case of shock, blood loss, hemorrhagic shock, but no, blood transfusion was given to him immediately without screening, okay, and 1 year later, same patient presented in the OPD with history of recurring fever, recurring diarrhea which is not subsiding, and after 6 months again the same person presented in the OPD with multiple recurrent infections, and on examination his CD4 count was decreased. This is a complete giveaway. CD4 count, T helper cells or T lymphocytes decreased. This is a clear-cut indication that the person might have caught HIV infection from that blood transfusion which was given 1 year before. So, what is the probable clinical diagnosis? Now it will be easy. It is possibly the HIV infection transmitted via blood. And what are the preventive measures to avoid it? Screening of the donor. And I mean, that would be the preventive measure. All right. Now going to the next. So it's simple. Just application of mind is required. Okay. A 17-year-old student presented to the emergency department after stab wound on the back. Stab wound on the back. Okay. On physical examination, there was significant muscle weakness affecting whole right lower limb. There was impaired vibration. Now see the clue. Loss of vibration, proprioception and 2-point discrimination. Means touch, pressure, vibration, proprioception was impaired on the right side and loss of pain and temperature on the left side, left lower limb. Can you guess what this condition is? Fine touch, pressure, vibration, proprioception lost on right lower limb and pain and temperature lost on the left lower limb. What is it? Come on, it's an injury to the spinal cord, injury to the vertebral column. Brown-Sequard syndrome, isn't it? So this is Brown-Sequard syndrome. They are asking, identify the clinical condition. This is Brown-Sequard syndrome. Name the tracts affected. You know there are these two tracts, the dorsal columns and anterolateral system. And give the physiological basis of the clinical features. You have to know the dorsal column and anterolateral system. Dorsal column fibers for the fine touch, they enter the spinal cord, they ascend on the same side. And pain and temperature comes into the spinal cord and crosses the midline and then ascends upward on the opposite side. This is the reason for such manifestations. All right. Not very difficult to understand once you know what are the key phrases, catchphrases. All right, let's go to the next one. Is it opening? Okay. So, Mr. Ranveer arose one morning from the bed and fainted. This itself is a clue. From lying down, the person came to standing posture and the person fainted. So, he was examined by a neurologist who, based on other symptoms and investigation reports, diagnosed him as a case of Shy-Drager syndrome. Now, Shy-Drager syndrome, they have mentioned a disease that will scare you. Don't get scared. Read the entire thing. As part of his treatment, he was instructed to elevate his head during sleep and wear support stockings to prevent blood from pooling in his veins. Yes, lying down posture to standing posture. There is pooling of blood in the lower limb veins. And he was also prescribed to take aldosterone analog to increase his blood volume. So, each of these measures were attempt to ameliorate dizziness and fainting. See, they have unnecessarily increased the jargon, use of words to scare you. The only important part was that he comes to upright posture and faints. That is because blood pressure decreases when you stand up and cerebral blood flow decreases. So the questions are, what could be the probable cause of fainting in this patient? This is called as postural hypotension. Postural hypotension, that the person going in upright posture, blood is pulled in the lower extremity veins, so less blood returns to the heart, cardiac output and blood pressure decreases. Name the reflex response and explain its mechanism of action which prevent blood from pooling in veins. Reflex, it's a Barrow reflex. It's a Barrow reflex that will increase his blood pressure and prevent that pooling of blood in the lower extremity veins. All right. So That's about the blood pressure and one application of blood pressure. Let's go to the next one. I hope that you can read these, but if not, kindly just listen to what I'm saying. Okay, the next one. Oh, can it increase in its appearance? Can it become better? No, I don't think so. Anyways, a 75-year-old man was admitted to the hospital with complaints of trembling of hands. Trembling of hands. So you know, tremors are of two types: tremor at rest and intention tremor. Tremor at rest, Parkinsonism; intention tremor, cerebellum. While holding a cup of tea, there is trembling of the hands. Difficulty in doing rapid sequential movements like pronation, supination, pronation, supination. There is difficulty in doing that. This is called as adiadochokinesia. Okay, so they have not given the key phrase as adiadochokinesia. Instead, they have given difficulty in doing rapid sequential movements. So by now it is clear that the question is on cerebellum. And then give the clinical diagnosis of the above condition. They have also mentioned past pointing was seen, etc., etc. It's clear that this is cerebellum. So this is a cerebellar disease. Explain the overall functions of the part involved. Overall functions of the part involved means cerebellum functions, cerebellar functions, and clinical abnormalities that you would expect in the above patient. Cerebellar lesions, effects of cerebellar lesions. So tremor, and then past pointing, adiadochokinesia, all those things. This is how they will ask cerebellum. Mainly these terms will be used. Inability to perform alternate rapid movements. Speech was also altered. There was hypotonia, pendular knee jerk. These are all the signs of cerebellum, cerebellar disease. All right, next. Next case is about a 45-year-old male has come to the hospital with complaints of excessive urination. Now look at this. Excessive urination, excessive thirst, excessive desire to eat, and tingling and numbness in the feet. First three things, it's clear it's diabetes, and the complication, tingling and numbness, means diabetic neuropathy. So we have come to a diagnosis straight away. Okay. Also there is muscle wasting. Answer the following questions. Name the clinical condition. Diabetic neuropathy, and explain the physiological basis of the above findings. Means why there is polyphagia, polyuria, polydipsia. Blood sugar has increased and glucose is not getting metabolized, so satiety center is not completely fulfilled or is activated, and therefore the person keeps on eating, resulting in polyphagia. And because the glucose is lost into the urine, by osmosis water is lost, there is osmotic diuresis and therefore increased urine output. And since water is being lost in the urine, there is excessive thirst. So such questions can be asked on the diabetes. Mostly the diabetes case is asked in very simple terms like this: excessive eating, excessive urine output. Describe the blood tests which are advised to confirm the diagnosis. Blood sugar, fasting, postprandial. Then GTT, glucose tolerance test. Normally it is only for pre-diabetics, the GTT. But then yes, blood sugar, and most important, HbA1c, glycosylated hemoglobin. Okay, so that was about diabetes. Be prepared for diabetes and pancreas. Okay, it's commonly asked. Right. Now I think this is about the endocrines. A 45-year-old woman has come to the hospital OPD with complaints of weight loss, increased heart rate, and heat intolerance. Heat intolerance, catchphrase, hyperthyroidism. Alright. So, answer the following questions. Name the clinical condition. So, this is hyperthyroidism, weight loss, increased heart rate. Explain the physiological basis of above findings. Thyroid means BMR. So, BMR increases in hyperthyroidism and therefore heart rate increases. There is increased heat production in the body, therefore heat intolerance. Now it's easy. And give the rationale of management. Well, in the case of hyperthyroidism, you will give anti-thyroid drugs. So rationale will be, they will decrease the effect of the excess thyroid. Okay, next. Are we getting it? The next case. But by now you are aware that it's easy to pick up the clue. One question out of the 4 may be out of your league, like completely medical, completely out in the medicine. You may have never read about it. It's possible, okay? No problem. You can still think of something. See, why NMC added this ECE in the first year itself? That they want to inculcate that habit of analysis. So, don't rely on previously read cases. You will have some new case. Go by that mindset. Okay. A 25-year-old male has been brought to the hospital emergency room with history of roadside accident, semi-conscious and sweating profusely. Excessive sweating profusely. His blood pressure is 90/60. So, blood loss, hypovolemia, sweating profusely. What is it? Come on. Circulatory shock. Yes. So, name the condition, explain the physiological basis of above findings and rationale of management. You must have read physiological basis of treatment of circulatory shock. Give oxygen, head low position, IV fluids are given because blood pressure is very low, and then the other treatment of the cause. So, therefore, you can just write, once you know what is the case, then you can write the theory part. It's always acceptable. I mean, there are questions to answer, but if you just write the theory that you have already read, even that is okay. Right, let's see the next case. Okay, 40-year-old person and complains of weight gain, fatigue, hair loss, constipation, intolerance to cold. Gone. I mean, answer comes out straight. Intolerance to cold and weight gain. What is it? Hypothyroidism. All right. So, what is your clinical diagnosis? They give other things also. Okay. They use lot of language and jargon to confuse you. But you hit the correct word and that's it. Answer will be straightforward. What is your clinical diagnosis and what is the physiological basis of clinical condition? Physiological basis of clinical condition. If such a question is there, then you just have to explain. Okay, this is where your explanatory power comes in. Weight gain. Why? You have to explain that. BMR is slow. That means energy is being conserved. Energy stored, weight gain. Or intolerance to cold. Why? Because the person is unable to increase the BMR while going into the cold. When the person goes into the cold, the BMR is not increasing. Heat production is not happening in the body. So, intolerance to cold. All right. And what investigations would you advise? If there is endocrine case, then you can at least mention 2 investigations. One will be the hormonal levels in the blood straight away, free T3, T4 and TSH. And then the other things, radio immunoassays, etc. Okay. Particularly in endocrines, you will have to also think about some biochemistry part. Lot of endocrine comes in the biochem. All right. A hypertensive male aged 38 years examined for renal blood flow with Doppler and found to have stenosis at renal arteries. His blood renin level is high. Blood renin level is high. So, explain the physiological basis of high renin levels. That means simply you are being asked to write renin angiotensin aldosterone system. Remember the first two steps, decreased blood volume and decreased blood pressure sensed by the receptors in the renal artery mentioned here, and then there will be secretion of renin, and then the renin angiotensin aldosterone axis flow chart has to be drawn. That's it. All right, next. I expect renin angiotensin system to be commonly asked in many universities, so be prepared for that. Long-term regulation of blood pressure or baroreceptor mechanisms in short term, I expect that to be asked very commonly, so be prepared for such questions. Okay, a 55-year-old male had attended OPD, all right, and her wife explained, this is what is written here. Her wife explained the complaints of her husband. Anyways, speech was slurred. There was impaired coordination of movements as well as unsteady gait, but no resting tremors. I'll read it once again. Speech is slurred. Impaired coordination of movements. Impaired coordination of movements. Who is the master coordinator for voluntary movements? Come on. Cerebellum. So this question is on cerebellum. Impaired coordination of movements. Speech also is slurred because it requires motor coordination and unsteady gait. So what will be the diagnosis? It's a cerebellum. Cerebellar involvement is there. Name two tests in the support of diagnosis. Test in the upper limb, test in the lower limb, you know it, and the Romberg's test, of course, don't forget that. Oh, what is the third question? Functions of cerebellum. Functions of cerebellum, that's the third point, third question. You will get such questions where in those 3-4 questions, they will straight away mention what the question is about. They have straight away asked functions of cerebellum, means this entire case was on cerebellum. That's quite apparent. Say thank you and write entire answer and get full marks. Okay, next, let's see at least 2 or 3 more so that you will get idea as to how they are asking the questions. But yes, as I said, look for the clue in those 3-4 questions which are there below the case. Okay, mostly the clue will be definitely there. Okay, a 66-year-old male sought medical care at the hospital due to severe chest pain. Chest pain. Alarm bells should start ringing. Chest pain, and along with maybe sweating, etc. So this is definitely, and they have given the patient was hypertensive and smoker. Does that ring any bell to you? Yes, smoker, hypertension, and now coming with chest pain. So this is definitely myocardial infarction. The ECG disclosed extensive ongoing acute myocardial infarction. So they have given ECG changes, ST elevation in some leads and ST segment depression in the opposite leads or inferior leads. And then the question, look at the question, what is myocardial infarction? Ischemia, loss of blood flow in some part of the myocardium, and necrosis followed by death of that region. That's called as myocardial infarction. You know that. Okay. Necrosis is cell death. And because of the cell death, if a region entirely dies, then it's called as the infarct. Infarcted area. Okay. Then the other questions were not even related. The second, third, fourth question. Like the second question is, write in brief about PR interval. Why would they ask PR interval? They could have asked the ST segment or whatever. But they are helping you. You must have read PR interval in the heart block, and therefore write about the PR interval. That's it. And long-term mechanisms involved in the regulation of blood pressure. This will happen. Very often the questions may be unrelated. They are just asking a case just to say that we have asked case in the exam. They are asking physiology in the garb of the clinical case. Camouflaged physiology. Okay, so no problems here. All right. Next, let's take one or two more and then you can go back to your studies. So far what have you got from this particular video is that the questions will give you the clue. Otherwise, questions sometimes will straight away mention, like they mentioned cerebellum. They write the connections and functions of cerebellum. So case is related to that. Or questions may be even unrelated to the case. Okay. We have two questions here, clinical questions. A 65-year-old patient is admitted with severe shortness of breath, which increases in recumbent posture. Now this is new. There is breathlessness or shortness of breath which increases in the recumbent posture. This typically happens in the heart failure conditions. Just as left ventricular failure, left-sided heart failure. So blood gets congested more and more in the pulmonary region, in the region of lungs. And therefore what happens is recumbent posture, there is more and more breathlessness. Okay, he gives history of weakness and exercise intolerance. Okay, so that means the person is definitely in heart failure. On examination, blood pressure is very high, heart rate is very high, bilateral basal crackles are present. Crackles or creps or crepitations, they are heard when there is accumulation of fluid. So this is definitely left-sided heart failure and therefore blood congestion in the lungs and therefore fluid leaking out of the pulmonary capillaries, and that's why it is giving creps, bilateral basal creps. ECG is showing left ventricular hypertrophy. Yes, left ventricular hypertrophy. But wait, no ischemic changes. So what is your diagnosis? And what is the cause of shortness of breath? Now this is something patient is probably patient may be having heart failure from the hypertension. Patient is chronically having high blood pressure and there is no exercise tolerance. I mean exercise tolerance is decreased in this patient. So person's physical activity is less. This is certainly heart failure then. Early stages of left ventricular failure. Okay, and which definitely happens due to high blood pressure. What is the cause of shortness of breath in this patient? As I mentioned, left-sided heart failure. So two things are possible. One is left ventricle is ejecting the blood into the aorta and arteries, and since there is arterial high blood pressure, so afterload on the heart is increasing. That may be one reason for shortness of breath. And the second, of course, is that the blood has got congested in the lungs and therefore fluid accumulation in the lungs causing shortness of breath. All right. Describe the LV PV loops. In the question they are asking to draw left ventricular pressure volume loop. So then you get the marks, and short-term and long-term mechanisms of blood pressure. So these are complete giveaway of marks. This is not connected with the question. Marks will be forthcoming. Okay. A group of third-year medical students accompanied a medical mission team to Peru. After arrival of the airport, they hiked quickly towards a remote mountain village. So the question is about ascent into the mountains and acclimatization. Once you know that, then they started suffering from headache, dizziness, nausea, shortness of breath. What is your diagnosis and what is it called, or what is it means compensatory changes in acclimatization? So straight away think about the acclimatization. What are the changes of acclimatization? Your answer will be correct and you get the marks. Anything else? All right, let's take one more. Acclimatization. First of all, during the ascent, there is hypoxia. Hypoxia stimulates peripheral chemoreceptors. It's going to cause increased ventilation and the resulting changes. Mountain sickness, chronic mountain sickness is called as Monge's disease. This is acute mountain sickness in the form of nausea, dizziness, etc. So, and then the acclimatization. Okay, let's take one more. A 60-year-old male is suffering from difficulty in initiation of any voluntary movement. Difficulty in initiating the voluntary movement. Okay. While sitting, he is having tremor in his hand, which stops during activity. Answer clear? There is tremor at rest, which disappears when the person makes the activity. What is it? Basal ganglia and Parkinsonism. In the basal ganglia, there is no drive to start the movement. Bradykinesia, Parkinsonism, bradykinesia, tremor at rest, etc. So explain the pathophysiology of the disease with a diagram. Parkinsonism, then show the direct indirect circuit by the diagram, particularly nigrostriatal tract, and the name 2 drugs which used to reduce the hypokinesia. They may ask drugs at times. And you know, in Parkinsonism, you give either L-dopa with carbidopa, L-dopa or levodopa, as dopaminergic neurons have been degenerated. But this levodopa will not be able to cross the blood-brain barrier, or it has to be combined with the dopa decarboxylase inhibitor, because dopa will be inhibited in the peripheral tissues by the dopa decarboxylase enzyme. So you add carbidopa. So levodopa and carbidopa combination. And if you remember in the lecture we said the other drug is anticholinergic drugs. Okay, because of that acetylcholine in the striatonigral neurons. Just go to the theory once again and see that circuit which I have described. So anticholinergic drugs and dopamine, or rather dopamine precursor. And what type of rigidity is seen? You know, lead pipe rigidity and or cog wheel rigidity. And the second case was very straightforward. Buffalo hump, moon face, purple stripe over the abdomen. What is it? Cushing's disease. Endocrines will be the easiest ones. Okay. Hope that the endocrine case is asked. That will be the easy giveaway, 5 marks or 10 marks, whatever it is. Let's go to the next case if it is coming up. I tried to make a folder of this, but it didn't happen. So I'm trying to take straight away from the mail on which I received all these cases. Okay. A 65-year-old male patient presented at the emergency with weakness of right upper and lower limbs. Right upper and lower limbs means weakness on one side of the body. Hemiplegia. On examination, muscle tone was increased. So this is hemiplegia, or let's say spastic paralysis. Spasticity, muscle tone has increased. And Babinski's sign was present. Do I have to even read further? They have given Babinski's sign present. So this is definitely upper motor neuron type of lesion. Therefore, muscle tone has increased. Hypertonia, you know, exaggerated reflexes. Babinski sign positive in the pyramidal tract lesion. And the questions will be related to that. Enumerate the descending tracts. Pyramidal tract and the 4 extrapyramidal tracts. Go to the theory, read it. And differences between UMN and LMN lesions. All this is theory. Okay. You will require a lot of theory in this. Look at the second question. The questions are unrelated to the case or mildly related. 75-year-old diabetic lady presented with fasting blood sugar of 220. Okay, so high blood sugar, diabetes, and urinary glucose is positive. Her GFR was found to be 65 ml per minute, and the questions are, what is GFR? So they have given a so-called case and they have asked theory questions. This is good. If they ask theory, that's good, because you have by-hearted the things. You can write the theory answers then which you have by-hearted. Less application of analytical mind and logic and more of the by-hearted stuff, isn't it? This is the last one. Okay, a subject presents with left-sided hypotonia, pendular jerks, nystagmus. CT scan reveals hemorrhage in the important structure of left side of the brain. So what that structure is? Left-sided hypotonia, pendular knee jerk or pendular jerks, and nystagmus. These are the symptoms of cerebellar disease. Okay, so there was blood loss in the region of cerebellum and the cerebellum has stopped functioning. So what are the afferent and efferent connections of this structure? Without mentioning, they have given you the clue. Afferent and efferent connections. In physiology, you have read only in one structure, and that is cerebellum. Please remember this. And also remember the afferent and efferent connections, all right? And then circuit. Then second case was middle-aged woman complaints of fatigue, sleepiness, amenorrhea, and progressive weight gain. Fatigue, sleepiness, excessive sleepiness, somnolence, and progressive weight gain. On examination, she is found to have goiter. So they have given the diagnosis themselves. Only thing is, what is the condition she is suffering from? Hypothyroidism. And then the next questions like name the hormone which is responsible here. Thyroid hormone. Synthesis of hormone in our body. Synthesis. Write down the synthesis of thyroid from iodine. Mechanism of action. Nuclear receptors. And explain the Jod-Basedow effect. Yes, something like this may be new to you. Jod-Basedow effect. Look, there is Wolff-Chekhov effect. That is, when you give extra amounts of iodine, it blocks the further synthesis of thyroid hormone. And therefore, sometimes giving of iodine is a type of treatment in hyperthyroidism. That the iodine uptake by the cell is by the thyroid gland is blocked and thyroid synthesis hormone is prevented. So iodine therapy as a part of hyperthyroidism, all right? And it works as a negative feedback also. When you give iodine, the thyroid will stop the secretion of TSH by negative feedback. That also is there. When that negative feedback does not happen, the patient comes out of that negative feedback and extra thyroid hormone synthesis happens, it is called as Jod-Basedow effect. So in a sense, coming out of Wolff-Chekhov effect is called as Jod-Basedow phenomenon. Okay, since it was mentioned, I thought I'll just discuss it in 2 minutes. So that was the video on clinical cases which you have been asking for. By now you must have realized that there is no need to panic, no need to create a monster out of it. It's going to be very easy. Look for those phrases that you have already heard and then go from that point onward. It will be easy. Thank you.